Thank you, Dr. Tipichat, and I would like to thank all the members, the Planning Committee of RCOST, and those in attendance for giving me such honor and distinction to present at such a conference. I'm really, really honored. Dr. Tipichat asked me to speak a little bit about quality of life in patients following surgery for bone sarcomas. And there are a lot of different variables that we can discuss when we talk about quality of life. And so I know there's a paper later in this session that focuses on specifically quality of life in patients who have knee arthrodesis for tumors about the knee. So I wanted to focus in this case to challenge a little bit about our thinking and our purpose of pursuing limb salvage surgery, and sometimes when we get in our head that amputation is a failure, whereas I think we need to think differently about that, and we need to be able to think not in terms of our success as the surgeon, of whether we were able to save a limb or not, but we need to think about how patients measure success. And just as we look at patient-reported outcomes, or PROs, in areas of spine surgery and total joint surgery, maybe this is an area that we need to focus on in orthopedic oncology when we really try and define what is the patient's reported outcomes with respect to quality of life. So what I wanted to do was really focus on amputation versus limb salvage surgery for patients treated with bone sarcomas. So I always like to start out that when I started as a fellow in 1990, there really wasn't a lot of patients undergoing anything other than an amputation. And if you looked at the National Institutes of Health, one of the largest centers in the United States at the time, treating patients both with bone and soft tissue sarcomas, you can see that really the purpose of surgery was to be able to do an amputation. And what defined someone to be an orthopedic oncologist was just whether you were able to do an amputation at this proximal level. At this proximal level, you can see in the lower extremity, the vast majority of tumors were treated with hemipelvectomy or hip disarticulation or above-knee amputation. And then in the upper extremity, you can see that the majority of patients who had upper extremity sarcomas required an amputation either through the shoulder or a forequarter amputation. And I wanted to start out the presentation looking at these two young girls who were patients of mine back in 1990. And you can see one of them had an amputation and the other did not. And when you look at function, you might actually say that the functional results of the girl on the left is actually somewhat better than the functional outcome of the patient on the right. But the important thing is that they're both happy. They're both smiling. They're both alive thanks to systemic chemotherapy and good surgery that involved a resection with a negative margin. So we really have to look at what are the things that define a successful outcome. I think if you talk to both of these girls, they would tell you that they had a successful outcome. And looking at their face, I think, speaks volumes. So I want to show two cases that I want you to think about and we'll revisit at the end of the lecture. So this is a 16-year-old male who had a high-grade osteosarcoma back in April of 2009. He got chemotherapy and had an excellent response. So I'm going to ask everyone mentally, not to vote, but just mentally think, what would you do for this patient? And this is another patient that I want you to think about as we talk about quality of life in patients with bone sarcomas, who's 8 years and 4 months. He's right-handed dominant, and he has a Ewing sarcoma involving his non-dominant left upper extremity. So what would you do? So we know that when we proceed with evaluating a patient with a bone sarcoma, the things we need to think about first is survival. And what we talk about is how do we ensure that the patient will have local control and systemic control But then in addition to that, we want to maximize function. So we're probably the most common location that's been studied looking at survival and outcome for patients who have had extremity sarcomas have been somewhat limited and mostly confined to patients with tumors involving the distal femur and about the knee. And again, one of the topics of our paper in this session deals with patients who have had knee arthrodesis for tumors in the distal femur. So one of the earliest papers that looked specifically at amputation versus limb salvage, but looked at not only the oncologic outcomes, but also at the functional outcome and quality of life study. And I think when I started back in the early 90s, I thought quality of life and functional outcome were very much related. And I would challenge you after this talk to determine whether you still believe that's true, because it does stray a bit from what I used to think, and I'm not sure that functional outcome necessarily translates into quality of life. And also functional outcomes is measured by MSTS or by the Knee Society score may not be an entirely accurate way to assess functional outcome, particularly in the athletic, male or female, who wants to pursue contact sports or downhill skiing or kayaking or some of the other sports that young people typically enjoy. So the questions that Dr. Rugraf and Niesel and Dr. Simon asked out of University of Chicago was, would limb salvage surgery decrease survival? So even in the 90s, we weren't convinced that limb-sparing surgery would affect survival. And then one of the important questions is whether there's immediate morbidity and what is the ultimate morbidity. So short-term and long-term morbidity associated with limb salvage. Does limb salvage improve function? Sort of intuitively, we like to think, yes, it does improve function, but I think I'll be able to challenge that thinking. And does limb salvage surgery offer a psychological benefit? And those questions have really been substantially answered. And we know that limb salvage surgery doesn't decrease survival in carefully selected patients. We know that the immediate and ultimate morbidity does have an increased number of procedures for patients who have limb salvage. Does limb salvage improve function? I think depends on how you measure function, and we'll go through that. But the answer is yes. And then does limb salvage offer a psychological benefit? I would say the answer to that is maybe. I don't think we really know. So as we look at this, we look at measures of quality of life, and we want to know, does improved function correlate with improved perception of quality of life? And perception means the patient's feeling about whether their quality of life is improved. And then we have to think about, does the risk and benefits of limb salvage surgery versus an amputation actually play a role in the patient's assessment of quality of life? So if they've had a limb salvage, had some complications, and have been through more than 1 or 2 or 3 operations, does this affect their ultimate sort of perception of quality of life? We know that as we evaluate quality of life in patients with limb salvage surgery, we have a difficult time assessing how quality of life is measured in what is a very specific patient population. And we know that outcome measures for quality of life in total hip and total knee patients is very different than for cancer patients and very different for musculoskeletal cancer patients. Studies have been mostly in non-cancer patients, especially in trauma patients, and we know that there's tremendous variation in patients who are treated with bone sarcomas, whether it's the site of the disease, the distal femur, the distal tibia, obviously have very different outcome measurements, what kind of prosthesis is used, and also there are probably some very significant cultural differences, where in some cultures, someone with an amputation might have social isolation, which contributes to their quality of life. And then sort of just in general, our response as a society of how we respond to people who may have had amputations and maybe suffer from other medical conditions, I think has changed dramatically. So how do we measure quality of life? And when attempting to assess quality of life, most tools assume that quality of life measures should include three primary functions. Those are physical function, mental health function, and social well-being. So what I'd like to emphasize is that we really need the right tool for the right job. And for a hammer, not everything should look like a nail. And for a screw, you need a screwdriver and not a hammer. So some of the most common measures that we use to assess quality of life, are certainly the simplest, is the short form, or SF-36, that I think most people are familiar with. The Quality of Life Questionnaire has been used. For patients with cancer, there's the European Organization for Research and Treatment of Cancer Quality of Life, which is a core module of 30 questions. There's the Brief Symptom Inventory, or the BSI, Impact of Event Scale, the Freiberger Life Continent LITS, and the Hospital Anxiety and Depression Scale, Life Orientation Test, and we could go on and on and on. And all of these have been validated, but they all have different sort of areas for which they've been validated for, and not specifically for patients with bone sarcomas. The SF-36 was originally developed in the 80s to assess the functional health and well-being of just any patient, whether it was a patient with hypertension or a patient with a gallbladder. So certainly not something that would fit our specific patient population. It's utilized in assessing both the general population as well as evaluating patients with specific conditions, and it's pretty simple to administer, so that's the one big advantage. But it certainly doesn't address our patient population. In 1989, though, we had the first functional scoring system that I'm sure everyone in this audience is reasonably familiar with, and it's the MSTS, International Symposium on Limb Salvage, or the ENICING functional scoring system. And this scoring system is also relatively easy to assess. Again, it's the patient who's supposed to report the outcomes. When I do it, I actually give it to the patient and I leave the room because we know patients want to make their doctors happy, and I think they'll cheat in my favor, and I don't want them to cheat. I want an honest assessment. The scoring specific, again, is very specific. It's based on the clinician's assessment of the patient's score from 0 to 5. 0 is the worst, and in 6 parameters. So the best possible score you can get is 30. It's been widely used for both validation and a reliable clinical research. And here you can see just how we use it. But note that this is a functional assessment only. It has very little to do with quality of life. And when you ask a 21-year-old whether they can do their household chores or not, I don't know about your 21-year-old, but my 21-year-old girl doesn't do any household chores. So it's not exactly the best scale. A more appropriate scale might include things like being able to go windsurfing, to be able to play contact sports, to be able to play volleyball or football or some of the other sports. So the downfall of limb salvage, we know, is that it increases the rates of infection and slight local recurrence, and often they need additional surgery, and some of those patients actually come to amputation. There's been very little evidence to suggest that limb salvage procedures either improve mortality rate or even decrease the disease-free interval. And again, we talked about Dr. Rugraff's study. Dr. Enneking followed up on that study with 227 patients and looked at eligible candidates diagnosed with high-grade non-metastatic osteosarcoma. So this is just the patient population with bone sarcomas, and they were treated with limb salvage, an AK, or a disarticulation. And we saw that the outcome for those patients, again, was no different than what we saw in Dr. Rugraff's study, even with an average follow-up of 12 years. There were no recurrences in the patients with the most proximal, but the important thing was they did show an improved function, but again, function did not correlate with an improved quality of life. So other validated measures, we talked about MSTS tests, and DASH for upper extremity is what the shoulder and elbow surgeons use. The Toronto Extremity Score looks at the functional assessment in patients who have undergone surgery for musculoskeletal tumors. It's been found to be valid and reliable. Again, a self-administered questionnaire. It's rated on a 5-point scale from activities that are either not difficult to impossible to do. And the importance of these terms is then rated on a scale to totally unimportant and extremely important. So now we're shifting to give a weighted score that addresses patients' sort of long-term goals and short-term goals. Quality of life assessment was then used by Paul Sugarbaker and his group, looking at 26 patients who were treated with amputation and chemotherapy or limb salvage surgery with radiation and chemotherapy. The results, again, did not show a significant functional difference. And then as we go through other tests or publications, Atkins showed the same thing. They looked at the functional ability of 118 patients with a minimum of 5-year follow-up. And again, the results were the same. 67 patients had limb-sparing surgery, but of those, nearly 8%, or 4 out of 67, ultimately required amputation. And they found that even using the quality of life SF-36, they found no clinically significant and health-related quality of life in patients who underwent limb salvage versus those who had amputations. So again, no significant difference. And patients who had a low MSTS score also had low quality of life. However, these groups were not significantly different. So we talked a little bit about how MSTS scores were generally slightly improved. The reintegration into normal life index is something that as orthopedic surgeons we don't really think too much about. We emphasize functional outcomes, but this is a little more complex. It's 11 declared statements through 7 different domains that include activities that you do indoor, community and distance mobility, the ability to self-care for yourself, daily activities such as school, recreational and social activities, family roles, personal relationships, and presentation of self to others, and your general coping skills. So this looks at things like depression and other factors. And again, another study by Malik looked at a retrospective study in 20 patients treated with MSK tumors, and they tried to look at a whole bunch of variables. That's why the small numbers. They looked at the psychological cost index, reintegration into normal life index, and again, SF-36. And they concluded that even though limb salvage improved function, again, there was no difference in perception of quality of life. So I think from our own experience, we can say that there are patients who come to us and maybe we're thinking of an amputation. And the parents are thinking, oh my God, that's a failure, that's a failure. And we know that 10 years, 5 years, even 2 years down the line, most of these people actually reintegrate very well. And I don't know why we're going forward, but let me see. This is a picture of a woman who had an amputation for an osteosarcoma at age 15. And you can see she's had an incredibly successful life as a writer and actress. She's a motivational speaker. She's a yogi, a vegan. And today she writes about her experience and gives motivational talks and is actually a world leader and someone who you can tell, despite an amputation, enjoys an exceptional quality of life. Other attempts to look at quality of life have been reported specifically in the pediatric population. They looked at 82 long-term survivors. A high percentage of these patients had amputations. And again, we saw, based on this study, quality of life questionnaire, psychological questionnaires with the Minnesota Multiphasic Personality Test, there was really no measurable difference. And then the European Organization for Research and Treatment on Quality of Life Cancer, again, a multi-dimensional structure. It's again self-administered, and it's applicable across a whole different group of cultural differences. And I can't emphasize enough some of the cultural differences that we see in patients in our own country, but also across different countries, that there are pretty significant differences of what patients are willing to accept. And I know that for myself, for example, I'm not doing this, I promise. I know for myself, for example, can we go back one? I used to be very opposed to doing rotation plasties, but I think there's been a real change in life and how patients accept, there we go, how patients accept rotation plasty has changed because there's really been a social revolution. So now we look at things like ability, I'm not touching it, I swear. We look at things like ability to participate in sports, employment, personality, psychological distress, and tumor characteristics. And I could go through many, many of these, but again, the emphasis is that there's no difference between, there's no correlation between functional outcome and quality of life. So what does it all mean? We've looked at all these different tests to try and distinguish, and we still can't find the difference. So is our assessment tool for quality of life sufficient? Is there a difference and our ruler is just not accurate enough? We know that the SF-36 is very widely used, but this doesn't show any difference. So how do we determine whether that is? While it takes into account the general parameters that make up quality of life, it still remains a very non-specific tool for quality of life. So does quality of life and function correlate? It seems like an obvious answer, but the data really does not support this. This may be due in part to the inaccurate measure of quality of life, and that we really need to find a more accurate tool. And do patients living with sarcoma, actually regardless of what their functional limitations, do they just really adapt? And is this an important thing in when we try and advise our patients about what the most appropriate surgical procedure are? So there are several limitations with all the studies. We talk more about functional gains are greater for more proximal locations, and that the distal femur and the proximal, the distal femur and the proximal pelvis have very different functional outcomes, but probably very different outcomes in terms of personal appearance, in terms of self-image, included body image, and sexuality. So, and we also know it's a lot easier, I swear I'm not doing it, it's a lot easier to develop a prosthesis for a lower extremity than it is to replace an upper extremity. So just revisiting our patient from with the Ewing sarcoma 8 years and 4 months ago, right-hand dominant male, with a 3-month history of increasing pain. You can see staging studies show solitary disease, pathologies of Ewing sarcoma. Then we look at this after receiving neoadjuvant chemotherapy, the tumors regressed, and he's really an excellent candidate for an intercalary resection. He undergoes an intercalary resection with an allograft in July. And then we didn't bridge the allograft, and you can see there's a space in between the distal and proximal hardware. So I would say this is a technical misadventure by the surgeon, and it was me, so I can be appropriately critical. You can see there's also a screw that's a little long, and that was impairing his function. And you can also see 6 months postoperatively, he's got maybe an early bit of a delayed union at the proximal site. So we went ahead, took out the screw removal to allow full flexion. And a year later and 1 month, this got excellent range of motion, but he still has a non-union of the proximal humerus. So he goes back for proximal bone grafting, and 4 months after proximal bone grafting, you can see some early union. And then 8 months post, again, you can see some early union. But then what you expected to happen from not bridging the entire allograft, 19 months following the surgery, he's got proximal and distal union, but he's got a fracture. So he goes back to the operating room now, and we revise him with a very long plate. So this is, I think, operation number 3. revision of hardware with a 12-hole locking plate, and everything looks pretty good, but not very good because we see that he still doesn't heal that fracture. The plate fails, the internal hardware fails, so now we're up to 4 operations. So we take him back and do a fibular strut graft and addition of BMP, which is very controversial of whether you can use BMP in the setting of prior tumor. But we chose to do this instead of a vascularized allograft. So here he is 5 years, 6 months after the index procedure with, I can't recall, 4 or 5 operations. But ultimately, you can see he's got a really remarkable function, and he does really well. And then if you remember the other kid that we saw in the very beginning, when you think about appropriateness of limb salvage for quality of life, this is the easiest straightforward case of a distal femur I've ever done. So this is pretty straightforward. Back in 2009, we were using cemented prosthesis. I probably would not use a cemented prosthesis now. But he went ahead and had a distal femoral replacement of A of 2009. And then this is a kid who works on the beach in Maryland. And like many of the people who work on the beach here, who's a lifeguard, maybe he drinks a little bit. And this particular kid drinks an awful lot. And so he's at a party on the beach, and he falls, and he develops an open wound over his distal femur and his thigh. And he waits 3 weeks before coming to the office with an open knee joint. So in the office, I can probe down to the metal prosthesis. So the fall on the beach, he presents with infection. We take out the hardware, or at least some of the hardware, put in an antibiotic spacer. The antibiotic spacer dislocates, so we revise the antibiotic spacer. Here he is with the antibiotic spacer for 3 or 4 months. You can see this is in 8/11. He ended up growing serratia. Then we put a long rod in. And you can see just more and more surgery. Patient still has his antibiotic spacer, and now it's a stable spacer. And here it is over the course of nearly a year, walking around on the beach with a fused knee. And this is a kid who just wants to get on with his life. He's 17 or 18 years old at that point. We revise him to a long rod with antibiotic cement spacer. We call this a pancake procedure. And then ultimately, I actually revised him to a non-cemented prosthesis proximally with a rapiphysis, so this is an extendable prosthesis. Because when we revise him for infection, we had to shorten the femur to allow for a wound closure. So he's doing well. Everything's going well. And then what do you think happens? He's on the beach. He's drunk again, having a party, and he ruptures his extensor mechanism. So we end up taking him back and taking out his patella and reconstructing his extensor mechanism. And 5 years and 1 month afterwards, he's doing pretty well, and we revised the expandable prosthesis to a fixed prosthesis. And then he develops a fracture distally. So the story just keeps on going. And anyone who does these limb salvage procedures can see this. So we try and treat this non-operatively, but again, as a 20-year-old boy, he's not going to do what we ask him to do. So he ultimately gets revised to a long plate and goes on to unremarkable fracture healing. In January 16, again, he's at the beach having a party and drinking, and he presents severely male-rotated, and everything looks fine, but clinically, he's severely male-rotated. And we weren't really sure what happened, but on the x-ray, you can see one of the knobs for the Moore's taper is broken. And we went back and revised the distal femoral component. Let me show you, that's that. So you can see where we revised the broken component, and you can see what his ultimate function is. If I go back, you can see he's shortened, externally rotated, he's got a limb salvage, but would it have really been a disaster if he didn't go through all this, and what is the effect of all this on his quality of life? So in conclusion, I'd say limb salvage still remains the gold standard for treatment of bone sarcomas when you can get a wide margin. There is no morbidity associated with limb salvage, but there is significantly morbidity, no significant mortality. Limb salvage has known inherent risks, including infection and need for multiple surgeries. And while patients gain from limb salvage and functional improvement, it does not necessarily mean that it improves their quality of life. Khap kun krap.